of our work to you, and hopefully you can all see the slides here through the platform. These are just my disclosures. As mentioned, I founded and am CEO of a company called Alto Neuroscience, where I get equity in salary as well as some other relationships. All right, so in terms of understanding where biomarkers, where EEG comes in with respect to psychiatry, and speaking now both as a psychiatrist and a neuroscientist, let me give you a little bit of perspective. And this is especially salient to the people, I think, who have not been treating patients on a routine basis, who don't understand this in a very granular way. If you look at essentially what you might call the sort of modern phase of psychiatry, that is the biology-interested version of psychiatry, where the biology that's of interest is that of the patient, as opposed to, for example, an animal model developing some mouse model of a disease. I think a lot of that push really got accelerated a little over 10 years ago with one of a slew of papers. This is one shown here where the headline's in The Guardian, summarizing it, which looked at all of the studies that have been submitted to FDA, as well as those that have been published on antidepressant treatment compared to treatment with placebo. And in that study, we're able to do a meta-analysis basically to ask, what is the net effect of the drug versus placebo? Their conclusion, at least as memorialized here in The Guardian, is that Prozac, used by 40 million people, does not work. Now, that was their interpretation. They saw Cohen's d effect size of 0.3. That was below what they considered to be clinically significant, but it was statistically significant. A couple of years before then, the STAR-D study, which is a very large NIMH-sponsored study, had also essentially published the top-line results that the overall response rates are meager compared to what we had expected antidepressants to yield when applied to a real-world population. So that really led to a lot of navel-gazing as far as the field has gone, a lot of trying of different things, some more successful than others, but really a desire to see something different. Then comes another paper, 10 years almost to the day, in The Lancet by Andrea Cipriani, that again was memorialized here in The Guardian. And its conclusions seemingly seemed opposite of the original one, despite using very similar methods. That is, that the drugs do work, antidepressants are effective. What's most interesting here is not necessarily that these two came to different conclusions, these two studies came to different conclusions because of particular reasons. They can be nailed down methodologically, they can be replicated, extended, but rather because they actually found the same thing. In both cases, they found a Cohen's d effect size of 0.3 between antidepressants and placebo, and yet in the one case thought that that means that the drugs didn't work. In the other case, we are now 10 years into really pulling out our hair trying to understand what's going on with our treatments. Why aren't they more effective, yet they seem effective for specific individuals, and perhaps that has reset the level that we were willing to accept as working. Their results were almost identical. And in fact, you see exactly the same thing in another study we published recently, which was a randomized trial that I'll show you some biological data for in a minute, of sertraline, the antidepressant Zoloft, versus placebo in about 300 depressed patients. So a very slight 42 to 34% advantage in response rates when you take all comers, that is, all depressed patients without biological consideration for, if you will, their brain type, and look at clinical outcome. So we're in now a situation where we understand that the true effect of these drugs on average in an unselected population of depressed patients, selected only by virtue of having the diagnosis, is real, is significant, but is very modest. And is the kind of thing that's hard to get patients and hard to get clinicians excited around. And that's really an important component here. Is I think the frustration in the field goes the full depth, all the way from the patient receiving the treatment to the people creating the treatments in the first place. But there may be a path around this, and that path may be through EEG. EEG has been studied with respect to its ability to predict antidepressant treatment response for a long time. This is a meta-analysis published in the American Journal not that long ago, just last year. And their conclusion, despite the ROC curve here that looks like you can predict treatment outcome to some degree, is actually that this is mostly due to small studies with very variable methods that never really tried to replicate methods across their studies, found unrealistic effect sizes, and perhaps is more likely artifact or opportunity around particular data sets than actual reality. At least that's their conclusion, though they were not by any means ready to dismiss EEG. This is more of a clarion call to doing it right, to doing the methods in such a way that they can be more robust, rather than saying EEG itself has no signal at all. So coming back to, to our clinical question here, which is what's going on with these treatments? Why do they seem effective, in fact, extremely effective for some people, and extremely ineffective for others? In fact, the standard story people will give you is that the way one gets to one's antidepressant of choice is through trial and error through multiple antidepressants. You never know which is going to be the effective one until, of course, you're there having received that benefit. I would argue that the path forward, and I'll show you some data for this, is by analyzing data such as EEG data, using machine learning approaches tailored for EEG that consider the nature of the data at hand and match it to the clinical data in a relevant way. However, machine learning isn't without its own challenges. We have to wrestle with a basic fact of EEG that there's volume conduction that happens, so there's a many-to-many mapping between sources of signal in the brain and what you detect on the scalp. There is an issue with any form of imaging, EEG being no different. You can measure many different things, and far more things in a single brain than you can possibly have patients in a study. So the dimensionality reduction is critical. And of course, with any machine learning method, the issue of optimization is a non-trivial one, because that's how you eventually get to the solution that scales, rather than falling into a local minimum. What I'll present to you are two general approaches at machine learning. One is known as supervised machine learning. The salient point here is that this presumes one has known targets, such as treatment outcome change in symptoms, that is, and you're trying to understand the heterogeneity in treatment outcomes per se, through heterogeneity in biology. So it's a very directed approach. The other approach is so-called unsupervised machine learning. Here the goal is actually to understand heterogeneity in the biology. So in both cases you're understanding heterogeneity in the biology, but in the second case, the primary goal is understanding heterogeneity in the biology, and the link to clinical is not necessarily part of that process. However, it sure would be nice if understanding the biology led to an understanding of the clinical. So that's really where the challenge lies for that one. We published several papers recently that I'll speak to the results of here that cover both of these domains. With respect to supervised prediction of treatment outcome, you can start with the same graph I showed you before, which is the symptom change, in this case plotted as response rate, when you try to predict that change using EEG taken pre-treatment at baseline. We developed a form of machine learning that looks at patterns of brain activity in a particular way, reduces dimensionality, and optimizes in a particular way to develop a signature for sertraline based on pre-treatment EEG. This sample size was far larger than what has been used before, and really allowed us to develop and to validate our methods in various ways. One way to visualize the result is now plotting response rates, but based on your predicted EEG, or rather EEG predicted response to sertraline. So what I'm plotting here are the lowest quartile, middle two quartiles, and upper quartile of people based on their EEG who had gotten sertraline in blue. And what you can see is their response rate goes, excuse me, in the lowest quartile from 20% to roughly 70% in the highest quartile. So a huge difference. Placebo was completely unrelated. Prediction was completely independent of the prediction to sertraline, and so that was flat across different sertraline EEG levels. But this tells you a couple of interesting things. Not only can you predict treatment outcome in a very robust and cross-validated way, but even more importantly, what it tells you that the proportion of people who are actually deriving a substantial clinical benefit from the drug are a small minority, let's say 25 to maybe a quarter to a third of people, a substantial minority of the people who get the drug in an all-comer analysis. So if you look to the left, that small difference is driven really by the proportion of people who show that strong phenotype because they're a minority. And that certainly leads you to think about these kinds of studies in a different way. Importantly, it's independent. This finding is independent of the severity of depression and works similarly across EEG systems and geographical clinical study sites. The other interesting thing that it allows you to do is once you've identified that signature, you can now go to other data sets and ask whether the signature tells you about something else that's useful, the same signature. Here we asked whether the signature told us about a treatment called RTMS, or repetitive transcranial magnetic stimulation, which is an FDA-cleared treatment for depression. The particular form that this related to is actually not yet FDA cleared. It's a low-frequency 1 hertz stimulation to the right side of the brain. So what we found is as follows. When you plot the response to RTMS clinically, based on the sertraline prediction by EEG, in the exact same manner as I plotted to the left for sertraline, what you see is an opposite relationship.
Amit, can I pause you just 1 second? We got a comment. We got a comment saying that the slides are not moving. Is that true? If others in the audience are seeing that as well, could you just put it in the Q&A box so we can make sure we don't have an issue here?
Yeah, for me, they're moving. I'm on the platform, so I'm not sure what the issue is.
Okay, great. Okay, thank you. Sorry about that. We just got a slide saying that it was seeing, they were seeing slides. Okay, perfect. Thank you so much, people. Sorry about that, Amit.
Yep, no problem. So, here, what we're seeing is an inverse relationship, or what you're hopefully seeing is an inverse relationship, such that the response rate is highest to RTMS for those who are predicted to respond most poorly to sertraline, whereas those predicted to respond best to sertraline actually have the lowest response rate with regard to RTMS. So it starts to support the argument that you can choose treatment based on this kind of information. So this is one picture. This is the picture from the supervised machine learning and particular features of the EEG. EEG, it turns out, is actually quite rich. There's a lot that can be gotten out of these kinds of data. And one of the things that interested us is seeing if we can get information about EEG connectivity at rest that tells us something like what fMRI would tell us. These same kinds of networks that people talk about with fMRI that have dominated the field for the past 20 years. And so we took note of Jörg Hipp's paper in 2012 reporting on power envelope connectivity, in this case with MEG, which yielded fMRI-like networks, and took that and translated it to EEG. This work was published earlier this year. So here you can see that using this method, which we then validated for EEG in various ways, you can see different parts of the brain and get the predicted networks that you would expect from fMRI, allowing us with EEG to interrogate some of these same systems in similar ways. We did that here in patients with PTSD. We looked at connectivity between regions of interest reflecting all the major networks that have been well described for a long time with fMRI, and plotted it here. What I'll show you is the plots for eyes open and eyes closed data at different frequencies in the canonical EEG frequencies as carrier frequencies for the power envelope connectivity. Looks like the plot may have some issues, but we'll see. Oh, no, there we go. So what you can see in the red and orange are the significant FDR-corrected significant differences between groups, which were almost exclusively in the theta eyes open condition, already telling us something interesting physiologically. If you zoom in, for example, on one of them, you see that, as in all cases, controls have greater connectivity than PTSD, and this is, for example, seeding a region in the middle frontal gyrus. So you can see is the difference between groups practically paints the prefrontal cortex bilaterally. So physiologically, anatomically, quite interesting. One of the things physiologically that theta, especially frontal theta, mediates is cognition. So we were interested in seeing to what degree that this kind of finding relates to cognitive differences between groups, which we know exist, versus symptom differences. Noting, for example, that in tasks like the digit span, performance in PTSD patients is reduced relative to healthy controls. And it turns out, if you look within these regions that are differentially connected between groups, there is a relationship to performance in the digit span task fairly robustly, but not to symptoms. So it's giving us a view, in a sense, like the part of the story about the supervised machine learning, giving us a view that we can now understand and see relationships to objective measures, to group differences that go above and beyond symptom differences. We can also use the same approach in another paper earlier this year, looking at either connectivity with this sort of measure that tells us who will respond to sertraline versus placebo, or what changes with sertraline versus placebo. But the most interesting thing that we found with these sort of data is actually a subtyping finding. So here, this is now the unsupervised machine learning that I mentioned. And it starts by just simply inspecting here the difference, the connectivity matrix here. These are brain regions on the x-axis, two brain regions on the y-axis, either in all the patients, in this case with PTSD, compared to healthy controls, or once applying a form of clustering to the patients, you can now see that there's, in fact, within that group of patients that seem different from slightly different from healthy controls, you can actually see that there is two very clear subtypes. One of the subtypes, subtype 1, has a pattern that looks exactly like healthy controls, whereas the other pattern, subtype 2, looks very different from healthy controls. So let's see how far we can push that difference and see what it tells us. One of the first things we did was to look across different cohorts of data. That is, different studies, 4 different studies, 2 of PTSD, 2 of depression, and found across all of those that we can identify these two subtypes first of all existed, and we can identify these 2 subtypes at better than 90% accuracy, no matter which cohort you use to train and which you use to test. They are different EEG systems. They had different clinical rating systems, and of course, different diagnoses. So these are now subtypes that seem quite powerfully evident across different disorders. Again, cutting across traditional measures or traditional ways to classify psychiatric patients. But ultimately, the question becomes, with any form of unsupervised learning, does it really mean something? Sure, you can find a difference. Sure, it's reproducible. That's great. But ultimately, is it telling us something clinically that could guide what we do? Is this revealing something about how you carve nature at its joints? So here we looked back at that depression treatment study called EMBARK and found that one of the subtypes, the subtype that was most different from control, subtype 2, failed to respond to sertraline any differently from placebo, whereas the response rate was substantially higher in subtype 1 to sertraline than placebo. In other words, subtype 2 seems to be treatment non-responsive to antidepressant medication. We then took that to one of the PTSD cohorts, which happened to have, which was pre-treatment in a study that had patients who were undergoing, in a structured way, psychotherapy treatment within the mental health clinic in the VA. These were all veterans. It was a very large study as well. And in fact, this study reflected two kinds of therapy: cognitive processing therapy and prolonged exposure therapy, which are, if you will, procedurally and conceptually, two very different kinds of psychotherapy. And there we found that subtype 2, again, had a very much reduced response relative to subtype 1 to either kind of therapy. And in fact, we can then replicate this in a separate cohort of patients undergoing psychotherapy. So it's a very robust and reproducible finding. And in fact, you can see here that the response rate is almost negligible in subtype 2. So if you're subtype 2 so far, that seems like pretty bad news. We then went to a third data set looking at two forms of RTMS treatment for depression and looked between subtypes. And there we found that actually the response rate was no different between subtypes to RTMS, to either form of RTMS. Again, suggesting that you can use EEG, in this case, born out of unsupervised machine learning, to select between treatments. So to pull this together, what I've shown you is that EEG actually carries a lot of clinically relevant, biologically relevant, and patient-level relevant signal that can be decoded through a range of customized machine learning approaches tailored for EEG. Those approaches identify a range of brain signatures based on supervised or unsupervised machine learning that can lead to either prediction of clinical course or even decisions around clinical treatment. Importantly, these insights are not possible from clinical measures alone. At every step of the way, we found that what we're learning is very different and additive to what we would learn from just clinical tools used in the clinic today, and that they were all very effective at cutting through heterogeneity, which has really been the thing that has plagued the field for the longest time. And this suggests near-term, clinically useful, translatable tool potential here. If you take EEG, you apply all these sorts of signals to it, it really suggests, I think, an exciting future, and frankly, one in which we can let go of arguments about whether our drugs work, but ask the more relevant question, which is, for whom does which drug work? And with that, we'll stop. Thank you.